Here, we'll be tackling on 4 cases which can be interrelated, and I hope you learn a lot from it. First off, the case is about a 39-year-old female who had rheumatic heart disease, and secondary to this rheumatic heart disease, the mitral valve developed a mitral stenosis, and later the patient succumbed into congestive heart failure and later died. Grossly, the heart was enlarged. Okay, the left atrium is more dilated and hypertrophied. And what's the reason why the left atrium is more dilated? It is because of the mitral stenosis. Okay. Next, the patient had a small left ventricle, a stenotic buttonhole like mitral orifice or fish mouth like mitral orifice. This is characteristic of rheumatic heart disease developing into mitral stenosis. Okay, a fused, thickened, shortened chordae tendineae and markedly dilated and hypertrophied left ventricle. Okay, this is the myocardium, hypertrophied myocardium. Okay, it's most likely this is the ventricle, and take note that in this picture it is the front face of the heart. Okay. So we're not looking at the heart as we are seeing it. We're facing the patient. No, it's the longitudinal section of the front face of the heart. Okay, so take note, these are hypertrophied walls. Okay, the case that we are focusing on is on myocardial hypertrophy. Okay, so this is the left ventricle with hypertrophied walls. Okay, how do you describe the hypertrophy here? This is what we call as concentric hypertrophy because the septum is as thick as the ventricular wall. Okay, histologically, the right ventricle myocardium has hypertrophied myocytes, increased cytoplasm and nucleus, and you see intracellular lipofuscin adjacent to nucleus. What is the indication of this lipofuscin? It indicates aging. So here is the slide of the myocardial fibers. Okay, what type of muscle it is? What? A cardiac muscle. Okay? It is a what? Involuntary but striated. Okay? This is the lipofuscin. This is the nucleus, lipofuscin, the yellow ones. Okay? And hypertrophy of myocytes can be as wild, no, as this one. Okay, this is the nucleus. This is the lipofuscin. You can see some intercalated discs here. Okay, and any question? So in the previous case, what we're focusing is on the myocardial hypertrophy. No, we have a lot of pathology in the first case. We have rheumatic heart disease, we have congestive heart failure. Okay, but it all had a characteristic myocardial hypertrophy. Hypertrophy of the myocytes. Okay, next, is a case of a 48-year-old obese male who was admitted due to a sudden onset of severe crushing pain on the left anterior chest, radiating to the left shoulder, left arm, and jaw, accompanied by diaphoresis, nausea, and vomiting, and the pain persisted and was unrelieved by rest. So this is how the patient looked like. Okay. So what are the differential diagnoses of a patient coming in your clinic or in the emergency room with an epigastric pain, with a pain on the chest? Okay. Okay. You mentioned about myocardial infarction. That's one. But what is the other differential diagnosis that is not cardiac, but we have to consider also? It is acute gastritis. First of all, myocardial infarction should be ruled out because it is an emergency. Okay? Okay. So why do you think acute gastritis or a case of GERD can mimic a myocardial infarction? Number one, it's because although it's gastric or esophageal in origin, the pain in the epigastrium travels to the upper part of the chest, okay, mimicking a heart attack. Okay, how do you rule out heart attack? You have to get the myocardial enzymes as well as ECG. That's the most basic. Okay. What are the pain? How do you characterize the pain of myocardial infarction? Okay. The pain is crushing. Okay, it's like you have an elephant on your chest. Okay, sitting down on your chest, crushing heavy. Okay, in the epigastrium or in the substernal. Okay, substernum. Okay, radiating to the left arm, particularly to the left jaw. Okay, radiating to the left arm, particularly to your small left finger. Okay. Radiation timing. How? What's the timing? It is sudden in onset and it is unrelieved by any medication and the pain persists for more than 30 minutes. Okay. And these are the warning signs. Okay. If you see a patient who has chest pain and who is cold and clammy, do not forget to bring the patient immediately to the hospital, to the ER. On admission, the patient was pale, slightly febrile, who was relatively hypotensive already, with a heart rate of tachycardic heart rate, and with tachypnea. Patient had faint heart sounds and premature ventricular contractions. Patient had leukocytosis, elevated ESR and LDH, and an ECG consistent with acute myocardial infarction with premature ventricular contractions. The patient deteriorated progressively, succumbed to congestive heart failure, and died 2 days later. This explains the fainted heart sounds. Okay, a while ago I was thinking about congestive heart failure, which was a consequence of this myocardial infarction, and true enough, the patient died of congestive heart failure. Grossly, the heart was enlarged and flabby. Okay? The patient had left ventricular hypertrophy with biventricular dilatation, and the coronary arteries had segmental atherosclerosis with calcification. Okay? And along with the atherosclerosis, you see an occluding thrombus, 2 cm from the origin of the left anterior descending coronary artery. And true enough, this artery is the most common epicardial or coronary artery that is being occluded in the case of myocardial infarction. And extensive areas of infarction are seen in the apex, left ventricular anterior wall, and portions of the interventricular septum. Areas of infarct shows pale yellow, soft, and hyperemic borders. So you might as well estimate how long this stage, what's the stage of myocardial infarction the patient is in. This is the gross picture of the heart, and this is the infarcted area. Okay. What is this yellowish thing here? These are fats. Okay. This is the heart, and this is the infarcted area. So it is dark in color because of hypoperfusion of blood and oxygen as well as nutrients. And in the cross section, you see the hypoperfused areas of the myocardium. Okay, and you see these are being highlighted by a chemical called tetrazolium chloride. Okay, tetrazolium chloride highlights the areas that have the enzyme that produce the enzyme LDH. Okay, so in the acute areas you have dark. Okay, and if you compare it to areas that already are chronic and those that are healed, okay, it's lighter. Okay, so here is a case of acute myocardial infarction. Here is a case of, most likely, a case here of a fibrosis. Okay, secondary to chronic myocardial infarction. The patient here did not just have an acute episode of myocardial infarction, but already had previous heart attacks. Okay, so here is another cross-section of an infarcted area. Okay, this one here. Next, we are lucky enough to see a thrombus occluding a vessel in the cross-section. Okay, and these are the morphologic changes as well as showing us the stages in acute myocardial infarction. So please study. So you see the changes in the heart. You see dark mottling. Okay, later developing into a yellow tan infarct. Okay, later developing into something that has central necrosis with hyperemic borders, and later developing into a gray-white scarring. Okay, so kindly study. And histologically, the patient had extensive coagulation necrosis with highly acidophilic cytoplasm, though the cell outline was intact. And you see a cariolysis, pycnosis, and karyorrhexis. These are characteristic of coagulation necrosis or even necrosis. Okay? And you see abundant neutrophilic infiltrates in between. Okay? So neutrophilic infiltrates, that is characteristic of coagulation necrosis. You see also congestion with red blood cells and hemorrhage. So here, these are the myocytes. Okay? And you see neutrophils inserting in between. Okay? You have to take a look at them closely because it's either you see neutrophils or RBCs. Okay? So you have to take a look at the slide closely. So here, these are neutrophils interspersed in between myocardial fibers. So any questions? So myocardial infarction, take note of the clinical presentation, take note of the stage where the patient is in during the heart attack, take note of the gross findings of the heart. Any questions? So next, a case of a 40-year-old male who died of uremia, okay, secondary to a chronic renal disease. Okay? And grossly, the heart was enlarged and it was indeed heavier than normal with a bread and butter appearance, secondary to a creamy white exudate covering the epicardium. The left ventricle was hypertrophied and the valves were unremarkable. So, creamy bread and butter appearance. There, covering the pericardium or the epicardium. So what are the considerations of having, by the way, this case is a case of a fibrinous pericarditis. What are the considerations? What are the causes of this fibrinous pericarditis? Number one, maybe an infection. Number two, as in this case, right? Patient had uremia. Second, myocardial infarction, because there is such thing as a post-MI pericarditis called the Dressler syndrome. Take note. Histologically, the heart is covered with a thick, highly eosinophilic meaning pink. Okay, it's not the eosinophil, huh? It's the uptake of the stain, no? Pink fibrinous exudate covering the epicardium, and the patient, the heart, the infiltrates that are predominating here are mononuclear cells or monocytes at the base of the exudate. So you see in the longitudinal section of the heart, you see a lot of things, layers. You see first the epicardium here, and you see fibrin covering the epicardium, and below that you have the epicardial fat, okay, and next is the myocardium. So you see, what's important here is you see a fibrin mesh or fibrin network covering the epicardium of the heart. Okay? And looking at it closely, you see inflammatory infiltrates. These are monocytes or mononuclear cells. Any questions? Any questions? So what's important here is you see fibrin, a fibrin network covering the epicardium. Next, this is a case of an aorta which has, which in the cross section we see atheromatous plaque. Okay, the other term for atheromatous plaque is an atheroma or atherosclerotic. So when we say atherosclerotic, the plaque has become hardened. Okay, what is the composition of these plaques? By the way, these are composed of many things. You see lipid, you see fats, you see collagen, you see muscle, okay, smooth muscle cells, okay, and we will see it. I think you'll be able to appreciate it in the lecture. In our slide here, we cannot appreciate the different parts of the atheromatous plaque, but anyway, we'll see later. So the atheromatous plaque are described as irregularly distributed, coalescent, with a small, slightly elevated soft and yellow, flat firm white, ulcerated with adherent grayish red thrombi. So why do you think the plaque developed a thrombus? So please research. And you see, the abdominal aorta is more studded with atheroma compared to the thoracic. This is the atheromatous plaque. When taken longitudinally, you cut it off, you scrape it off, and you see the plaque. Most probably, the red ones here are the thrombosis. Okay. And this is a case of an aneurysm with a thrombus as well as an atheromatous plaque at the longitudinal section. Another, this is a plaque, but we see what you call these holes. These are what we call as patty streaks. These are actually made or the work of macrophages that eat up the lipid that go into the blood vessel. That's why you have holes. The fatty streaks is the earliest hallmark of atherosclerosis. Histologically, the intima is markedly thickened, of course, because of atherosclerosis. Okay? Atherosclerosis is not as simple as, the fat lining up the blood vessel wall. It gets complicated because the fat becomes incorporated into the blood vessel wall. And what makes it worse is that the smooth muscle becomes or what they call this, the blood vessel forms a new tunica intima, okay, or what you call as a neo, how do you call this, neo-intimal proliferation of smooth muscle cells, okay. So you see a highly collagenized tissue. Okay, these are the parts of an atheroma. You see a fibrous cap and you see a lipid core. Okay, the fibrous cap is composed of a highly collagenized tissue with calcium deposits. We also see fibrin. We also see smooth muscle cells. Okay, and the lipid core is composed of the following: all the cells that eat up the fats, okay, is what we call as the composition of the lipid core. So you see the foam cells, okay, you see the LDL, okay, low density lipoprotein, the cholesterol, okay, we see it there, and a damaged elastic lamina and superficial muscularis. Okay. Ideally, we will be able to appreciate the atheroma, okay, an intact atheroma, an intact blood vessel. Okay, this is the atheroma here, and this is the thrombus occluding. In reality, when you look at it in the microscope, the thrombus looks more redder, okay? It's more erythematous, okay? And of course, if you look at it closely, it's composed of red blood cells. However, there are some cases where the thrombus does not occupy what they call this, the central part of the, or the luminal part of the atheroma. Okay? Okay. So why, again, why do you think thrombosis is a consequence of atherosclerosis? What is the trigger for the formation of thrombosis? Which comes first, the atheroma or the thrombus? So please research. This is another. So this is the thrombus, this is the atheroma. And this is a slide that talks about the pathogenesis of atherosclerosis. Okay? So what is the first, the trigger of atherosclerosis? It is endothelial dysfunction, secondary to chronic endothelial injury. Okay? So if your answer is endothelial injury, that is still correct. Okay? So you see, you have a endothelial dysfunction leading to increased permeability, wherein anything that is listed here, you have hyperlipidemia, you see even blood sugar, okay, becomes the blood vessel wall, okay, becomes what they call this permeable to these substances, and because there is permeability, you have activation of these white blood cells, the macrophages as well as the platelets. And because you have endothelial dysfunction, the reaction of the smooth muscle is to produce another layer of smooth muscle at the top portion of the tunica intima. Okay? So now you see a atheroma in between. You see this is the lipid core. This is the fibrous cap. Okay? And what are the consequences of atherosclerosis? So first, formation of thrombus. Why do you think thrombus formation is a consequence of atherosclerosis? It is because the lipid substances, or whatever you have, sugar, glucose, okay, these are atherogenic, or these are thrombogenic. Okay, this invites the formation of the thrombus. Okay. Next, formation of thrombus. Secondary. Next is you have aneurysm and rupture. Okay. So when the thrombus, okay, occludes the vessel, as well as the atheroma occludes the vessel, and you have hypertension, you have increased of the pressure inside, and the vessel wall is weakened. Okay, you have aneurysm. Next, what's another fate? You see plaque hemorrhage, bleeding. So there might not be a formation of a thrombus, but a bleeding. Okay. Next, you have, if there is no thrombus formation, you will still have progression of this atheromatous plaque, which leads to a critical stenosis, which can still lead to heart attack. What are the consequences of a thrombus? So a thrombus, when it is formed, it can develop into or propagate itself. Okay. Next, it can be lodged. So that is what we call propagation. It can be lodged to another area. That is what we call embolization. It might become dissolved, okay, because of fibrinolysis. Okay. If the patient is taken in aspirin, okay, it is a blood thinner. So the thrombus is dissolved, or within the thrombus, if the thrombus is intact, okay, there will be a recanalization or formation of collateral channels or vascular channels within the thrombus. Thank you so much.